In this video, we'll cover everything you need to know about pericarditis. We'll also listen to a number of patients' hearts with pericardial friction rubs. Before we get started, remember to check out the Murmur Master App, which contains hundreds of heart sounds recorded from real patients. It's also got great summaries on a huge number of valve lesions, so you can quickly get to grips with key bits of information from presentation to management. You can also test your skills with hundreds of quiz and test questions. The pericardium is a double-layered sac that surrounds the heart. It consists of an outer fibrous layer, which is tough, and an inner serous layer that is smooth. The serous layer itself has two components, a visceral layer, which is tightly attached to the epicardium of the heart, and a parietal layer, which is attached to the fibrous pericardium. There is therefore a potential space between the two layers of serous pericardium, which normally contains a small amount of fluid, around 10 to 25 mils. The serous pericardium has specialised microvilli on its surface which secrete pericardial fluid. Pericarditis describes the inflammation of the pericardium, and it's the most common pericardial disease. There is an inflammatory infiltrate into the pericardium, including inflammatory cells such as neutrophils as well as fibrinous material. Around 50% of cases of acute pericarditis are associated with pericardial effusion, which describes an increase in the amount of fluid in the pericardial space. So what are the causes of pericarditis? The majority of pericarditis is idiopathic, which means it has no identifiable cause. The second most common cause is infectious, mostly viral or post-viral, for example after upper respiratory tract infections such as influenza or adenovirus, or fecal-orally transmitted enteroviruses such as Coxsackie B virus, which usually cause mild gastroenteritis illnesses as well. Worldwide, tuberculosis is a common cause, but this is very rare in the developed world. Next, inflammatory and autoimmune causes. Dressler's syndrome describes pericarditis that usually develops weeks to months post-myocardial injury, such as myocardial infarction or surgical or percutaneous intervention. It is thought that the initial myocardial injury causes damage that exposes new antigens to the immune system, which then results in an autoimmune attack on the pericardium. Similarly, inflammatory connective tissue disease can also cause pericarditis, such as lupus or rheumatoid arthritis. Next, metabolic derangements such as uremia in acute or chronic renal disease are well described to cause pericarditis. Finally, other causes are much rarer, including drug-induced pericarditis, trauma, and malignancy or paraneoplastic disease. Let me know in the comments below whether you've seen patients with pericarditis where there's been a specific cause suspected. How did you diagnose and manage it? Also, it'd be great if you give the video a like and subscribe so it can help more people learning cardiology. What are the symptoms of pericarditis? The main feature is pericarditic chest pain. This is usually sharp, central or left-sided pain that is classically worse on deep inspiration or lying flat, and better when sitting forward. This occurs because lying flat or deep inspiration brings the anterior chest wall more into contact with the pericardium, which can worsen the pain. Patients may not describe these features clearly, so it's important to elicit them either by direct questioning or asking the patient to lie flat and or breathe deeply when assessing them. Pericarditic pain often radiates to the inferior angle of the left scapula. Next, patients often describe flu-like symptoms such as a fever, myalgia and arthralgia, malaise or cough. Finally, sometimes patients can develop myopericarditis where there is also a myocarditis element. The symptoms can be less specific, but may also include shortness of breath, especially if there is a left ventricular impairment and heart failure. Let's now consider the signs that may be present in a patient with pericarditis. A pericardial friction rub is a pathognomonic auscultation feature in acute pericarditis. It is highly specific, although its reported sensitivity varies, occurring in between 30 to 85% of cases. It's a scratching and or grating sound, usually heard best at the left lower sternal border with the patient leaning forward. It occurs due to abnormal friction between the inflamed visceral and parietal pericardium. Let's have a listen. It's classically triphasic in nature, with sounds occurring in systole, as the ventricles contract, early diastole, as the ventricles relax, and late diastole, as the atria contract, as each of these phases results in movement of the visceral under the parietal pericardium. The loudness of the sounds may decrease if the patient develops a pericardial effusion, as it separates the layers, hence reducing friction. We'll cover pericardial effusions in a separate video. So how do we classify the different durations of pericarditis syndromes? Acute pericarditis describes symptoms that develop acutely and can last up to 4 to 6 weeks. Incessant pericarditis is where acute pericarditis symptoms linger for longer than 4 to 6 weeks, but no more than 3 months. Chronic pericarditis is where symptoms last for more than 3 months. And finally, recurrent pericarditis is where symptoms associated with an acute episode resolve and give way to a symptom-free period of at least 4 to 6 weeks before recurring again at a future point. What investigations are important in helping to confirm a diagnosis of pericarditis? We'll look at blood tests, the electrocardiogram, the chest X-ray, and the echocardiogram. Bloods are an important investigation as they usually show raised inflammatory markers, for example, raised C-reactive protein, erythrocyte sedimentation rate, and white cell count, especially in acute pericarditis. These can be normal, however, especially if the patient presents within the first few hours of symptoms, as these markers have not had time to rise. It's important to also perform cardiac biomarkers, such as troponin. This is mostly to identify those with myopericarditis, which would usually cause an elevation in cardiac biomarkers due to myocardial inflammation, but are also used to exclude acute coronary syndromes. Next, the ECG has pathognomonic findings. There is classically widespread ST elevation in a pattern non-consistent with territorial ischemia, that is, spanning the anterior, lateral, and inferior territories on the ECG. The ST elevation is usually concave, like the shape of a smiling face, and there is no reciprocal ST depression, other than perhaps in lead AVR. There is frequently PR depression below the isoelectric line, as shown in this complex. Let's compare a pericarditic ECG to an ischemic one. Ischemic ST elevation is more convex or tombstone-like and occurs in just 1 or 2, but not all 3 territories, and is associated with reciprocal ST depression, unlike in pericarditis. Here we can see ischemic ST elevation in the anterolateral leads, with reciprocal ST depression in the inferior leads. Beware of any ECG labelled as pericarditis with significant ST depression in any lead other than AVR, as this is more likely to be ischemic. How can pericarditis be differentiated from benign early repolarization, also called high takeoff? Benign early repolarization also presents with generalized concave ST elevation in the precordial and limb leads, but the degree of ST elevation is often less than a quarter of the height of the T wave, whereas the ST elevation in pericarditis is usually more pronounced. Additionally, benign early repolarization often has notching of the J point, which is the junction of the QRS complex with ST segment, as shown in this ECG. The chest X-ray in those with pericarditis is usually normal, but could reveal malignancies or evidence of infections. If a large pericardial effusion is present, there may be cardiomegaly. Finally, what about the echo findings in pericarditis? Echocardiography is not specific, but there are several suggestive features. As mentioned, around half of patients develop a visible pericardial effusion on echo. Pericardial effusions can be small, less than 10 mm, moderate, 10 to 20 mm, or large, greater than 20 mm. Echo can also identify signs of impending cardiac tamponade, although this is a clinical diagnosis. Finally, there is often said to be hyperechogenicity of the pericardial layers in acute pericarditis. To diagnose acute pericarditis, therefore, at least 2 of the following 4 clinical features are required. Firstly, pericarditic sounding chest pain. Next, the presence of a pericardial friction rub. Thirdly, new widespread ST elevation or PR depression on the ECG. And finally, a new or worsening pericardial effusion on echocardiography. So how do we manage pericarditis? I've based these on both the American and European guidelines, links in the description. First-line treatments for acute pericarditis include a non-steroidal anti-inflammatory drug, for example, oral ibuprofen 600 mg every 8 hours, which is generally used for a duration of 1 to 2 weeks or until symptoms have resolved. Gastroprotection in the form of a proton pump inhibitor is often co-prescribed to reduce GI side effects. Additionally, colchicine at a dose of 500 micrograms once a day if less than 70 kilograms and twice a day if over 70 kilograms should also be used first line alongside an NSAID for a period of 3 months. Continuing colchicine for this duration is thought to reduce the rate of recurrent pericarditis after the first episode. It is generally well tolerated but can cause loose stools and diarrhea. If the patient has a contraindication to NSAIDs, for example significant renal disease, then colchicine is often used alone. If NSAIDs with colchicine are contraindicated and/or fail to achieve symptom resolution, corticosteroids can be used as second line, often alongside colchicine. They are usually used in low doses of around 0.5 mg per kilogram per day, or prednisolone initially, or equivalent. The dose must be tapered slowly to prevent recurrence of pericarditis symptoms. They are not used first line due to the side effects and the fact that they may increase the risk of recurrences of pericarditis in the future. Steroids can be used first line, however, where there are specific indications, for example, if the cause is thought to be an autoimmune disease, but they should not be used where bacterial pericarditis is suspected. What about lifestyle recommendations? Both American and European guidelines also recommend exercise restriction until symptom resolution in the general public, and for 3 months in athletes. Exercise-induced tachycardia may increase shear stress on the pericardium, which is thought to, in turn, increase oxidative stress, hence worsening inflammation. Additionally, pericarditis has been associated with exercise-induced sudden cardiac death, probably because of concomitant myocarditis. So how would one go about managing a patient presenting to hospital with suspected pericarditis? First, the diagnosis needs to be confirmed with a history, physical examination, ECG and blood tests. In most cases, the exact cause is not confirmed directly, for example with a sample of pericardial fluid, and is instead attributed to either viral or idiopathic etiology. Next, a decision needs to be made about whether to admit the patient to hospital. Ideally, all cases should be triaged with an echocardiogram on presentation to help make this decision. Low-risk cases are generally discharged and managed as an outpatient, depending on local policies. High-risk cases usually require admission to hospital for observation and investigation. Key reasons to consider a patient high risk include raised cardiac enzymes, likely indicating myopericarditis, but also necessitating the exclusion of acute coronary syndromes. Next, a large, purulent or tamponading pericardial effusion. And finally, cases where a specific etiology is suspected, such as an inflammatory or bacterial cause, for example indicated by sepsis, or where patients are immunocompromised. High-risk cases may benefit from inpatient investigations, such as pericardiocentesis, to collect a fluid sample from the pericardium and process it for analysis, and/or advanced imaging techniques, such as cardiac magnetic resonance. What is the prognosis of acute pericarditis? The majority of acute pericarditis, especially of idiopathic or presumed viral origin, is self-limiting, with up to 70 to 90% of cases resolving without any future problems. What about the potential complications? Firstly, pericarditis can result in the development of a large and/or tamponading effusion. It is most common in those with a specific etiology, such as malignancy or bacterial infection. Next, up to 30% of untreated patients with acute pericarditis develop chronic or recurrent disease, but this rate is significantly reduced by treatment with colchicine. Finally, pericardial constriction is a rare complication where the pericardium thickens and fibroses over time in a way that prevents the two serous layers from moving freely over one another. This prevents the ventricles from filling with blood properly, ultimately causing heart failure. It is very rare in viral or idiopathic pericarditis, but is more common in tuberculous pericarditis, complicating as many as 20 to 30% of cases. The only definitive treatment is a surgical procedure called a pericardiectomy, where the fibrosed pericardium is stripped from the heart. And that was a Murmur Master summary on pericarditis. If you found the video useful, remember to like and subscribe. Also, check out the Murmur Master app on the App Store for more content like this. See you next time.